the psychological makeup and motivation of that person operating on you does determine the chances of you having a good outcome or not a good outcome. That's the reality. We're really lucky in ophthalmology that even in the hands of someone that isn't exceptional, the outcomes are still likely to be very high in many of the operations we do, especially on the front part of the eye. But the difference between a 1% problem and a 0.1% problem or a 0.01% problem is that psychological piece.
Welcome to the OT podcast, which takes a deep dive into the topics affecting optometry today. Each time we'll find a real expert in their field and attempt to pull everything we can out of their brain so it may reside in yours. This is the 12th episode in the series, and we are recording on the 8th of July 2024. You can listen to the other episodes on the OT website, on Apple or Spotify, or from your usual podcast provider. In our 12th episode, we'll be speaking to Allon Barsam. But first, I'll introduce myself. My name's Kerry Smith-James. I'm the clinical multimedia editor for Optometry Today, and I'm also an IP optometrist. I practice in the northwest of England.
And I'm Ian Beasley, Head of Education for the AOP, and also clinical editor of Optometry Today, and a visiting lecturer at Aston University. So Kerry, before we welcome our guests, perhaps we should highlight some of the CPD that we've got available. I know you'll be keen to talk about CPD video.
Yes, as always, I have a video bias, but we've just finished for provider-led CPD, the surgical solutions for presbyopia, and that features Allon Barsam. It's still available in the OT education library, so you can always watch that and then upload that for self-directed CPD points. But currently the live video is Enhancing Glaucoma Detection, and that's with Jennifer Blackmore in partnership with Zeiss. This is one that we filmed at 100% Optical 2024, and it's all about the use of OCT in glaucoma, and that's going to be live until the 1st of November. What articles have caught your eye?
Well, it chimes nicely with Allon being our guest in that both of the articles that I'm about to talk about link to cataract surgery. So first of all, there's an article that discusses risk factors for intraoperative complications during cataract surgery and aims to highlight the importance of thorough examination and history taking during the pre-operative consultation. And then a second article that looks at the importance of evaluating the ocular surface prior to cataract surgery, once again to limit the potential complications that could otherwise arise. Kerry, I think it's also worth touching upon something in the CPD requirement space. So we're recording this on the 8th of July, as you've said already, and just last week, all registrants would have had an email arrive from our friends at the GOC to announce that the reflective exercise is now ready to complete on the GOC portal. And I must confess that I haven't really got my head in the game yet when it comes to the reflective exercise. I know that you're one step ahead of me, as always, and you've got a much better understanding of what's required. So perhaps you could just take us through some of the key points.
As this podcast will be live in September, so that means there's 3 months to go to perform and submit your mandatory reflective exercise. So basically what you need is another peer, and you're going to meet on video, phone, or in person. And you're going to have a little look at the CPD that you've done over the cycle. You're going to use your personal development plan. That's something you should have written and uploaded quite early on in the cycle. And possibly you've altered it and changed it over the 3 years. That's perfectly okay to update it as your plans change. So you sit down with that peer and you reflect on what you've done. Maybe have a look at some of the reflective learning statements that you've done for things like peer review. Have a little look at the things that you did manage to achieve, the things that you didn't, and maybe why. Have a look at the little gaps in your learning that you might want to fill in. Have a plan of your CPD for the next cycle. So the next 3 years, what do you want to move into? Is there anything else that you need to cover or new fields that you want to get into? So of course a peer is defined by the GOC. So in this case, it can be an employer or a line manager, an optometrist, a dispensing optician, or another healthcare professional. So for example, that could be an ophthalmologist, an orthoptist, a nurse, physiotherapist, or a pharmacist. You're going to need their GOC number or their other professional registration number, and you also need their email address. the GOC will be verifying that some of these reflective learning exercises took place, so they might actually want to contact that peer and check with them that it did happen. The peer cannot be a close friend, a relative, or an employee. So if you are the main employer in your practice, you might need to look elsewhere to find someone to do this reflective exercise with. So things to do now: work out who it is you're going to partner with, ask them, set a date, update your PDP, ensure you've uploaded all your CPD to your MyGOC account. You're responsible for uploading your own points in this new cycle. And have a look at your CPD so far, look for any gaps, and maybe find some CPD to fill in those gaps. One thing to note, you need to submit your CPD reflective learning exercise before the 31st of December. There's a template on the MyGOC that you can use, but you're going to have to fill that in and hit submit before the 31st of December 2024 if you want to stay on the register.
This OT podcast is supported by the Association of Optometrists, who would like to invite listeners to support its campaign calling for long-term change that will transform eye care for patients. As many as 5 million GP appointments are made each year for conditions that optometrists are trained and qualified to manage. The current system is under severe strain, putting unnecessary demands on GPs, but optometry is part of the solution. With your support, the AOPS campaign, 1 million appointments, can shine a spotlight on the GP access crisis and how optometrists across the nation are equipped to relieve the burden. To find out more, visit aop.org.uk/1 million appointments.
It's great to welcome our next guest, who's Allon Barsam. Allon is Director and Founding Partner of OCR Vision, and an elected council member for both the UK ISCRS and the BSRS. He's been a consultant since 2012, specialising in laser refractive surgery, cataract surgery with advanced technology lenses, and corneal surgery. He's published over 45 peer-reviewed scientific papers, 16 book chapters, and he's the co-author of a comprehensive textbook of ophthalmology, which is now in its 3rd edition. Allon is a key opinion leader for the ophthalmic industry and is regularly invited to chair events and lecture both nationally and internationally. Allon was the first surgeon in the UK and one of the first in the world to carry out SmartSight Calyx laser vision correction. Allon, welcome to the OT podcast. Thank you for joining us. As always, it's quite nice to start the story from the beginning. So maybe if we can just rewind, I don't know how many decades, but to when you were a med student, at that point, did you know where you wanted to go and sort of perhaps take us through that journey to where you are now?
Sure. Again, I'm having to go back a long time to answer that question. When I was a medical student, there was no run-through training in any specialty, in fact, except for, I think, general practice. So every single medical specialty, you could spend some time in that specialty before deciding if you wanted to continue in that specialty or move to another specialty. The more competitive specialties, of which ophthalmology has always been competitive since I've been practicing medicine, did require some thought early on in your training because there were so many hoops to jump through in order to try and get into training. It's not a kind of open door policy. It's not a kind of a question of, well, if you get these grades in A levels and you go to medical school, you can just choose to become an ophthalmologist. The numbers will have changed slightly, but they haven't changed that much actually over the last 20 years. And when I applied for what was at that time registrar training, which is after you've already been a junior ophthalmologist for anywhere from 2 to 5 years, there were only 80 places in England each year. So that's the bottleneck to get into ophthalmology. So I actually made the decision a bit later than most, I would say. Some people actually go into medicine knowing they want to do ophthalmology. Normally, as it happens, optometrists get into ophthalmology that way. They start in optometry, they learn optometry, they practice optometry, and then they feel that they want to do more medicine or more surgery that can only happen if you then do a medical degree. So there are some pretty well-known examples actually in the UK of people that went in through that route. And then there are some people that just seem to I don't know how people make decisions so early, but it's quite difficult in medicine to know what kind of a doctor you want to be before you've actually been responsible for looking after your first patient. In any case, for me, I had thought from medical school that what I would most want to do would be to be a physician, which is basically a medical hospital doctor. And the reason that I liked that is because I found it intellectually stimulating in terms of it's a bit like the medical equivalent of Sherlock Holmes, who was, by the way, also a doctor. You're piecing together little bits of information, try and work out what is wrong with a patient, and then you can apply the cure or the treatment appropriately is the idea. But I also did feel that I would enjoy and be able to contribute positively to something in which there were procedures involved. So I just had this sense that I was good with my hands. And I found that the mainstream surgeons they're quite a unique breed. I don't know if you've come across many kind of out and out general surgeons or orthopedic surgeons. It may be different now. This was, we're going back to when I was training 25 years ago or more. It's actually almost coming up to 30 years ago when I started training. But anyway, a long time ago. And I just didn't feel you need mentors, you need people to inspire you and people where you think, I could see myself doing that job or working like this person works, especially in something that's psychologically taxing, involved, which is many healthcare jobs, but certainly a surgical or medical specialty. So I didn't feel I related to surgeons. So I just thought, look, I'll be a physician and I'll do procedures, interventional cardiology, gastroenterology. Those were the things that kind of appealed to me. And then it was the very end of medical school. And in those days, you were encouraged and allowed to do a lot more than I think you would be these days. And I was in the emergency department, and I remember it very clearly. It was like 3 or 4 months before I was due to qualify as a doctor, and someone had chatted up the wrong person's girlfriend in a bar, and that person took exception to that and decided that they would take a pitcher of beer, smash it in the guy's face. And he was cut from his forehead right through his face, right down to across his lip and down to his chin, like a really would have potentially been a very disfiguring injury. And the plastic surgeon came in and put like 2 or 3 key stitches in and then left me to do the other 30. And I was with this guy for over an hour or 90 minutes, putting all the stitches in. And I just felt so connected with what I was doing. It was such a kind of pure moment of problem and treatment and cure that I just thought, like, I can't justify only doing a medical specialty because what I most love is the procedures. I should do a specialty where surgery forms a greater part of it. And I still felt reluctant to do kind of out and out surgical specialties because of the personality types that exist within there. And I still liked the idea of the intellectual pursuit that you have through diagnosis and treating patients. And so I was in the library bored when revising for finals, looking through the postgraduate exam qualifications, which I knew was going to be the next hurdles after medical school finals. And I was reading what at the time was MRC-OP, the member of the Royal College of Ophthalmology exams. And I just thought the questions were really interesting. And I thought there's neurology here, there's anatomy here, and there's all elements of medicine and only applied to the eye. And I imagine that surgery is demanding and requires quite a particular mindset and hand-eye coordination and skill set ability. And I think I might be okay at that. And then went into it after that, and then fell in love with it. But there's a huge amount of fortune, I think, to choosing. And that's true, I think, of any career, not just in medicine. But I thought I might be good at it, but we see so many driven, motivated people coming into ophthalmology expecting to be able to do it, and it's a very unique skill set. Eye surgery. I liken it a bit to, obviously the implications of getting it wrong are not the same thing as losing a life when you're playing a video game, but it does have that same hand-eye coordination requirement because we don't see our hands when we're operating, something that people don't realise. Our instruments are in our view because everything is so magnified, but we don't see our hands. So it's quite similar to when you're on the screen playing a video. And I know this because my brother was 10 years younger than me and was quite video game obsessed. So I was playing video games quite a lot actually as a teenager, which I think helped me to develop those kind of neural pathways to make ophthalmic surgery come quite naturally to me. But, you are moving your hands and then relying on what you do with your hands will affect the change that you then see in your field of view. It's quite a unique way of coordinating that is not the same in any sport, for example. It's not the same in any kind of other kind of fine manual task. It's really just microsurgery and video games.
Just picking up on that, Alan, is the training in any way gamified these days?
Yeah, simulation has become much bigger in recent years, and there are now some big players in the tech world like Meta, who I believe are doing some work with virtual reality and surgical training with respect to kind of cataract training and ophthalmic training. And it's hugely additive, because when I learned ophthalmology, there were no simulators. There was a very good wet lab that was run at the Royal College of Ophthalmologists, where there were artificial eyes. So you get the idea of instrumentation and handling of instruments and use of a microscope. And you can also pick up things like how you feel when viewing the eye through the microscope by assisting. So the microscopes all have assistance pieces where we can see in 3D. So the other thing that a lot of people don't realise is that when you go into an operating theatre for eye surgery, you normally see the surgery on a screen. But when you're actually doing the surgery, everything is in 3 dimensions and the structures of the eye are all clear. So you're working in kind of multiple planes through clear structures. And the requirement for stereoscopic vision is high. We used to check each other, because if you don't have good stereopsis, even if you have some form of microtropia or something of that nature, it massively limits your ability to do microsurgery. But, the first time that I did a cataract operation, a full start to finish cataract operation, was on a live, awake human patient. That's the reality of it. You start in steps, you do one bit and then the other, and then you go through and do the whole thing. And I'll never forget how much fear you feel when you're doing that. Even when you make your first incision, it feels so unnatural to take a blade and put it inside someone's eyeball. I mean, as I say it, that sounds quite obvious. But when you're training to do it and it's all that you see, and I do believe that the best surgeons do experience that emotion, because we all have varying degrees of emotional self-awareness or awareness of what the impact of what we're doing on other people. And I think that's an important piece. I've been fortunate that I haven't trained anyone at a senior level where I felt that wasn't the case, because I was involved in recruiting fellows and bringing them in, and I wanted them to be human beings who would care about what they were doing and who would live and die by their success or failures surgically, because I believe that's how you become better as a surgeon. But there are many surgeons out there who, with huge egos, who don't allow themselves to experience those unpleasant emotions, and they will not be as safe on account of that.
Is that something you advocate working on, or do surgeons generally just work on practicing the actual minutiae of doing surgery, or do they ever actually take any time to work on that side of themselves and the psychological impact and the emotional side?
The fellows that I've trained in the past, and that's the kind of people that are functioning at the most senior level, but also, I've encountered more junior trainees who are coming in. The thing that I first of all do, providing they don't have a major dexterity issue, which is rare. So it's rare that a trainee just, literally can't coordinate in order to allow themselves to be safe. But there is a huge gradient of ability of people that are, able to operate safely and people that really excel. So you have that gradient of ability, but that kind of natural ability is almost irrelevant when you're training someone. It's obviously nice if someone does have that ability, but I've operated on some very, very capable surgeons in terms of their hand-eye coordination who are not the safest, because they can cut corners, they can rely on their reactions, they can get away with things that they might not otherwise be able to, which isn't necessarily good in that kind of feedback loop of learning to be safe. So that psychological element of where is their state of mind and how that impacts on their performance is massively important. And I felt that was my main job. It was almost like a psychological coach. And I don't know if my fellows would convey that they had an awareness that I was doing that, but that's very much what I felt I was doing, so that they can learn to harness any fear that they feel and channel that for a positive, accurate and safe outcome for the patient. And the ability to be reflective is also important. I don't know if you ever saw that. If either of you seen the film The Last Samurai?
Yes, but I don't remember it well.
It's a Tom Cruise film, but there's a scene in it that I often tell trainees about, which is it's towards the end of the film where he's basically a fully fledged samurai at this time point. He's defending someone and he's involved in a fight, and it all happens very quickly. I think he's being attacked by 4 or 5 people, something like that. And at the end of the fight, when they're all basically down, he just kneels and meditates. And on the screen, they show you the flashback in his mind of all of the sequences involved in the fight. And he then realizes that one of the people he had only injured but not killed because of the strike or the blow that was required. And that person is standing up behind him, ready to finish him off. And he basically stands up and responds. And it just shows you that I love that scene because there's that awareness of being reflective. And in surgery, that's really important. Now we can record everything. It's very easy to record cases. But what I used to do is ruminate. So I would do my surgical days and my surgical procedures, and I would ruminate on those procedures. In my mind, I would replay them, how they went, what was happening. So I would be picturing the surgery that I had done in my mind again and again. So it's like you amplify the experience that you get to allow you to take it forwards. And there's another film that I often recommend people watch, which is Sally. It's the film about the miracle on the Hudson, because that pilot, people say, well, that was a one in what happened. They advised him to turn back and he didn't have enough fuel. So his only option was to land the plane on the river, and water landings with jumbo jets are like exceptionally difficult. But he used to do the same thing. He'd be driving along in California, and in his mind, he'd be playing through every single eventuality that might happen when he was flying. So although he'd never been in a situation where he had to land a plane on water, he had envisaged that scenario in his mind and was therefore like not panicking and ready for it and knew what to do. I'm sure that patients would love it if they could imagine that their surgeons to somehow be these kind of perfect robots where accuracy, predictability, and making every single decision correctly is guaranteed. And that's just not the case. Maybe one day with AI, with robotics, with all the technological advances that are coming into medicine and surgery, that will change. But right now, you have a human being operating on another human being. The psychological makeup and motivation of that person operating on you does determine the chances of you having a good outcome or not a good outcome. That's the reality. And we're really lucky in ophthalmology that even in the hands of someone that isn't exceptional, the outcomes are still likely to be very high in many of the operations we do, especially on the front part of the eye. But the difference between a 1% problem and a 0.1% problem or a 0.01% problem is that psychological piece, combined with whatever the actual ability level may be. But none of us can choose our natural ability level. We only choose, what we do with that. And I think that the more I get through my career and the more other people I experience and the more I experience people who are successful in other elements of life, not just within, surgery or medicine, and the more I realize that it's that motivation piece, that work piece, that mindset piece, that's I think what's the discriminator. The extraordinary people are the people that are prepared to do extraordinary things to be extraordinary rather than that they're born with some extraordinary gift.
And do you think that drove your decision to move into your subspecialty and tackle that sort of complex anterior segment work that you sort of that's the route that you took? I think you were responsible for setting up a tertiary NHS service, which involved all of that complex work, corneal transplantation. Do you think it's your psychological profile that drove that decision, or is it what you alluded to earlier, which is the outcomes for anterior segment work is more likely to be favourable versus maybe some of the retinal stuff?
I actually kind of battled with this exact question at about year 7 of my 10 or 11 years of training, because I really loved vitreoretinal surgery. I loved it because it was challenging and because the kind of dexterity requirements were high and because it was such an out-and-out surgical specialty that you were guaranteed to have a certain level of complexity in your surgical work that you do. Whereas in anterior segment surgery, there are some corneal surgeons that work in units where they just do kind of cataracts and then medical cornea rather than all of the different forms of transplantation. And yes, I made that decision to do anterior segment surgery because I felt more so than with retina surgery and glaucoma surgery and other elements of intraocular or microsurgery, all of which are challenging, those specialties. But I felt that within anterior segment surgery, what I would or would not be capable of doing surgically would have an impact on that patient's vision and therefore their life. That burden has stayed with me all my life. But so is the challenge and so is the reward. And, I certainly don't regret it, but I don't think I quite appreciated what was in store for me at that time, because I was so young when I made that decision. I was, that would have been 17 years ago now or something, maybe more. I said, right, I'm going to now try and specialize in anterior segment surgery. And I think I was quite lucky that during that time, lamellar corneal transplant surgery was rapidly taking off. Many of the techniques had only just been described, or they certainly weren't mainstream. When I made the decision to go into it, it was really just penetrating keratoplasty. I think people had described anterior lamellar keratoplasty, but endothelial keratoplasty had, may have just been some kind of laboratory thing, or it was really in its infancy. It was not in mainstream clinical practice, and people were just starting to do it within a few years of me making that decision to go in. So corneal surgery quickly became significantly more involved. It went from predominantly one kind of corneal transplant to 3 over the time that I was training. And then DMEC, which is the kind of endothelial, the membrane endothelial keratoplasty, I actually learned after I was a consultant. So I went to Rotterdam with Ali Mirza, who was, had always been a long-standing mentor, friend and colleague now. We went to Rotterdam to learn the technique from Gerrit Mellers, who had described it. And that was in, I think, 2014. So corneal surgery certainly came on leaps and bounds. And that element, that kind of challenging element of surgical work is something that I still enjoy. In fact, in the current 4 or 5 week period, I would have done one of each of those transplants. So 1 deep anterior lamellar keratoplasty, 1 penetrating keratoplasty, 1 DSAEK, and 1 DMEEK just in the last month. So it's become very common now to do the lamellar surgery.
Do you think that we'll get fewer of those in the future because we're performing corneal crosslinking on the young keratoconics? Is those lamellar surgeries, are they going to become less useful?
Yeah, I think so. I think that you're already seeing that. I do not see anywhere near as much advanced keratoconus as I used to. When I first became a consultant, which was 13 years ago, to now, the severity of keratoconus. I mean, you do still see some cases, but nowhere near as much. The awareness of crosslinking is very high. The NHS, I think, has been very effective at rolling out crosslinking and making it available to people and screening people, and that's a good thing. I mean, it's better for people not to develop disease and to have a disease and then it require a very involved surgical process to see well. And I think with endothelial keratoplasty, there are now injection techniques and drops to encourage endothelial growth that people are now using. So it may be that those endothelial keratoplasty surgeries will also eventually become obsolete.
And Alan, you mentioned Ali Mirza, who's now a colleague of yours as a result of setting up your private practice, OCL Vision. It seems that OCL Vision has grown very rapidly over the last few years. So what's that journey been like, and how does that compare? That brings different challenges, doesn't it? Suddenly you're in business, and it's not just about patient care. How do you handle all of that?
We made the decision to set up OCL Vision because we didn't feel that within the private sector, at least in England, there was an organisation where there was surgeon or physician leadership, where you had surgeons basically leading the organisation that was bespoke for private eye care. Most of the ophthalmologists in the UK who do private surgery do it within general private hospitals. The BMIs, the Spires, the Nuffields, the HCAs, and they don't get me wrong, they're great places, but it's not exactly the same thing as when you have every single person that is involved in the pathway of the patient only involved in that one specialty, which is eye care. When you have nurses that are cross-skilling in orthopedics, or when you have even the kind of secretarial team, when it's the reception team, they're dealing with patients from all different kinds of diseases. It's very different having a kind of 85-year-old wheelchair patient because they have some kind of hip problem for an orthopedic surgeon compared to an ambulatory 32-year-old laser vision correction patient, for example. And although at OCL Vision we do all specialties in adult, it's still all eye care, and there's so much crossover. We're updating now our do's and don'ts, our drop sheets, our advice on how patients recover from surgery. And we can do that kind of collectively in a way that maximizes the patients having a safe recovery and a seamless journey. In terms of the business element, the thing that's always driven all of us in OCL Vision, and it's very much part of our culture, is the impact that our work has on our patients. So you could see that as something that is of value. And that is the same thing that businesses are trying to achieve. They're trying to create value. So for us, the motivating factor in terms of why are we here? Why are we doing this? What is it we want to do? Is to basically improve people's lives. It's our kind of tagline. It's the improving vision and lives with excellence in care. That's what OCL Vision's all about. And our core values is trust, teamwork, and excellence. And we believe that we are stronger together. You know, there's this expression that says that if you want to go fast, go alone. If you want to go far, you need to go together. And that's what we want to do. We want to try and raise the bar for private eye care in the UK, multi-specialty. I don't believe it's good for patients to have a refractive lens exchange where they don't have a retina surgeon available in the unlikely event there's a problem, or if something materializes late down the line. You know, we're operating on high myopes, and you know, maybe they'll get a pressure problem when they get older to have the glaucoma surgeon. So there's that multi-specialty piece as well, which means that people come to OCL Vision, they know they're going to have eye care fully looked after. Sometimes they come for refractive surgery and we see that actually there's something we've seen on the retina that they didn't know about, and then we'll ask one of our retina colleagues to have a look at it. So, you know, people will have referral pathways out elsewhere, but not within the same umbrella organisation in this way. So we think it's a kind of powerful platform in which private eye care can and should be provided in the UK. And our plan is to use the business for exactly that. We do not want the opportunity for surgeons and patients to either carry out and or experience eye care at OCL Vision to be limited just by the surgeons we currently have and the locations we currently have. So our plan is to try and move into other areas in England or the UK to make that available to more people.
So predominantly you're based in the southeast, I guess, but you're looking but you're looking to move further north or southwest, or
we will look for opportunities to partner with other surgeons, for other surgeons to kind of come up through the ranks and to make this kind of level of eye care something that people can experience in other locations.
Well, we'd certainly welcome your team up north. I think there's certainly demand in my area. You did talk about the patient impact and the impact on their lives, and we have someone here on the podcast right now who if he's willing can directly talk about that. He is sat here right now without any spectacles or contact lenses in, having been quite a high myope in the past. Ian, do you want to tell us a little bit about your experience?
Yeah, I feel in some ways I feel a bit guilty as an optometrist that maybe I didn't offer laser as a viable treatment option to many of my patients. And I found oddly being a high myope, I think I was minus 750, minus 3 cils. Allon, you might remember before you treated me. Perhaps wasn't the easiest case you've dealt with. I had high expectations, which you delivered on, so thank you. For me, oddly, it wasn't the high myopia that was the issue. It was when I started to become presbyopic that I felt really miserable. I had surgery, I think 7 years ago now, and what caught me by surprise is the quality of vision that I enjoyed following the laser surgery. I deliberately asked to be left about minus 1-ish because I spend most of my life doing close-up stuff. Even being uncorrected minus 1, the quality of my vision at all distances was just way better than being fully corrected with specs or even contact lenses. And that really caught me by surprise. And as I say, I feel guilty that maybe I didn't give that opportunity to many of my own patients to talk more about refractive surgery as a solution.
I was just going to say, I remember at the time you saying you're a little bit cross you hadn't done it earlier.
Yeah, I'm sure I think I said that to you at the time, Allon, and you said, yeah, everyone says that.
It's difficult. It's difficult also to compassionately educate optometrists on the topic, because it very much depends on what the situation is of that individual optometrist. But, you know, Ian, you're involved so much in kind of education, in academia, and you come across all kinds of optometrists. And optometrists, I think, that have large, busy and holistic practices in the community, I find are generally okay with the idea of refractive surgery because they just see it as one option for patients of many. But there are some optometrists out there where, you know, dispensing glasses and contact lenses is just like their bread and butter. And they can't reconcile the idea that although glasses and contact lenses are good for many, they might not be good for everyone. And it's easier just to say, oh, you shouldn't do this because you have astigmatism, or you shouldn't do this because you're too young, or you shouldn't do this because you're too old, or you shouldn't do this because your eyes are dry. And although there are many reasons why people shouldn't get laser vision correction or any kind of vision correction option. It's almost impossible for even the most kind of up-to-date, educated and technology exposed optometrist to know that in the community. That is the kind of job of the surgeon. So the frustration from our point is that more optometrists don't say, okay, you've asked me about laser vision correction, and given that you're obviously thinking about it, maybe you don't feel so comfortable or happy with your glasses or contact lenses, otherwise you probably wouldn't ask me this question. And given that you've asked it, I think that you're likely to be motivated to seek vision correction surgery, whatever I happen to say to you. And as it happens, I do know of a good practice or a good place or a good person that I would recommend, and this is who you should go to. But I think what many optometrists do is they use kind of outdated or potentially nowadays old-fashioned adages as to why people shouldn't get laser refractive surgery, and those people come anyway. Like if they are asking you, what do you think about it? And they will know that, or they may suspect that the optometrist is saying you shouldn't get it for X, Y, and Z reason. And they'll think, well, that's strange because my 3 mates have had it and they had astigmatism, or they're my age, or they also had a bit of dry eye before due to their contact lenses or what have you. But I think that it would be better to try and break down that whatever the kind of conflict is, if you like, the business or commercial conflict between refractive surgery and dispensing optometry, if you like, to just say, look, we're here to make people's lives better and this is not for everyone. We know that many patients are really happy with glasses and contact lenses. I would never expect an optometrist, for example, to promote that anyone should get this done because it's an intervention with risk. But if someone is asking already about it, then they're already thinking that they're having problems with glasses and contact lenses, and they might not feel comfortable saying that to their optometrist. Sometimes people don't want to, they don't want to say, actually, I'm finding glasses and contact lenses difficult. And they're in an environment where they know it's all about the glasses and contact lenses, right? They're up on the wall, they're being advertised, they're often being worn by staff. It's just a different kind of environment. But, the option is there for those patients that are motivated. And I think that communicating that is part of holistic optometric eye care, which is important.
I have a sheepish confession in that before we filmed the Surgical Solutions for Presbyopia video recently with Allon Barsam, I had a conversation with a friend, someone at a sports club, who was plano distance and just starting to get annoyed with reading glasses. And I must say that my conversation with him was sort of, well, but by doing some surgery to an eye that is actually pretty perfect, you've got everything to lose, haven't you? And I realised actually that was probably a wrong thing to say, and I was doing a bit of a disservice because there are actual solutions for presbyopia, and as you said in the video, a lot of work that we do now is close up. Our world has gotten more close up than it ever was. We're looking at phones all the time and screens all the time, and distance is less of a priority than it was. So maybe you can tell us just a quick rundown of some of the new advances in presbyopia.
Yeah, I mean, that's a good question. And I think what I would say about that is that I think we take for granted as eye care practitioners what we understand about useful vision and quality of vision. And we might think, look, you've got fantastic vision in the distance, 20/20 for both eyes. And we know that that's going to give you the best quality of vision in terms of stereopsis and contrast sensitivity and all of those things. But that doesn't tell you what is useful for that person. And the ability to only be able to see in the distance without the need for glasses is prohibitive for some people. It depends what they do, but I've looked after photographers and artists and sometimes musicians, and this like the need for kind of okay distance and then glasses, and some people don't get, as you know, will not get on with varifocals. So there are that piece of like being dependent on glasses for near is a real problem for some people. So I think presbyopic solutions are becoming more used and more understood, but it still is mostly in the remit of more advanced practices, if you like. The high street, I don't think have really fully adopted, certainly presbyopic laser. They do kind of push and encourage refractive lens exchange more. There may be commercial reasons for that, because although refractive lens exchange is a good option for some, I still feel that presbyopic laser vision correction is not offered enough as a first choice to people who could otherwise safely have it, because it still remains, of all the surgical interventions we do, it still remains the safest. It's not intraocular. Any of the problems that might arise on the cornea are treatable. So it's a part of the eye that it basically is presenting itself for treatment and also for problem solving in the unlikely event that things arise. But I like many of the kind of mini monovision or the monovision type approaches, and it's different with a surgical solution which incorporates monovision compared to straight monovision in contact lenses. And the reason that it's different is that the contact lens monovision options normally don't allow for inducing small and non-toxic amounts of spherical aberration for increased depth of focus. So the new lenses that we use now with lens exchange or cataract surgery, which are extended or increased range of focus lenses, some of them work by induction of small amounts of spherical aberration. And most of the presbyopic laser vision correction options that are available also work by the induction of small amounts of spherical aberration. So by increasing the depth of focus, we don't need to target as much myopia in the non-dominant eye, residual myopia or induced myopia if they're hyperopic, as you would do with a contact lens. So whereas you might, if you were doing monovision on someone that's well into presbyopia, you might think, well, in order to see really well, they might need minus 1.75 or minus 2 in the non-dominant eye. With presbyopic laser vision correction or lens exchange cataract surgery with extended range of focus lenses, we often will target around minus 1. So there's very little offset between the two eyes, but they gain a lot more and they can still read really well. If you imagine your kind of monovision contact lens patients having half the amount of monovision, but still the same amount of reading vision, that's what we're often able to achieve. Most of us feel that the way to communicate the potential for refractive surgery is to underpromise and overdeliver. You know, if you look at papers, you can see, and you can read many papers that have been written on this, literally hundreds of papers. Statistically, people are likely to have better quality of vision after laser vision correction than they do beforehand with glasses and contact lenses. So although you said it was a surprise to you, Ian, it was not a surprise to me, but I wouldn't have necessarily beforehand said this is what you can expect because it sets the bar really high. And also, we don't know for sure exactly what the quality of vision is for each individual patient with contact lenses and glasses. You'll see it with some of your patients where you refract them, you prescribe it, and you put it on, and some people are like, wow, that is perfect, that is amazing. And you know that they'll be achieving really great quality of vision with those glasses and contact lenses. But for many, that isn't the case. Doesn't mean they're complaining, but for whatever reason, slight aberrations, reflections, the fact they don't bother cleaning their glasses and they get smudged, whatever their day-to-day issue is with their glasses and contact lenses, although they feel like the vision's very good, many people after laser vision correction will feel that it's better. And that I think is true with presbyopic surgery as well, not necessarily with respect to what they would necessarily perceive with a distance vision, but their overall quality of vision they feel happier with because they have a more natural range of vision. Not being able to see your near world at all is obstructive for many patients.
Yeah, I think I never quite understood the story as much as I should have done before having laser. You'd read these success stories of laser and what percentage of patients are going to achieve 6.6 or 6.5 after surgery, but that tells such a small part of the story, and it is more about that aberration correction or whatever it is that just affords you that just completely different visual experience. And it's definitely not about VA for me, or it wasn't for me. It's so much more than that.
And it's also something that people that are quite demanding also do benefit from. It's funny because I can remember when I was training in refractive surgery, they would have these stereotypes of patients and they would say, look, for example, engineers, architects, people that do these very particular jobs, saying, look, you should avoid these patients. And I was, set up my private practice in central London and in North London. And I was thinking, well, if I avoid people that are kind of particular, I won't have no practice like that. Like if people are that laid back, they don't come to you with a problem with glasses and contact lenses. Like really laid back people are like, yeah, this is fine. They just keep going. They're not a problem. It's people where they're like, this is bothering me for X, Y, and Z reason. Though that is your refractive patient, so it is kind of proven to be successful in those cases, and the satisfaction levels are really high, really high across the board in big studies.
And thinking back 7 years ago from when I had LASIK, if I'd come to you today for a consultation, would I still be having LASIK, or are there newer techniques out there that you would prefer to opt for?
Yes, good question. And I can't remember exactly what your corneal profile was like before, but I do now use SmartSight, which is a form of Kalex. It's keratorefractive lenticule extraction. It's very similar to Smile, which people are more familiar with, but with a Schwind platform. So it has an automated computer-based way of measuring and tracking what's called cyclotorsional control, which is astigmatism treatment. And also it has live tracking of the pupil, so it is able to deliver a kind of nighttime pupil measurement. But also it can be delivered without an edge cut. So we can do thinner lenticules at the edge. So we think maybe dry eye recovery will be even better with SmartSight than it is with equivalent techniques like Smile. But SmartSight has now become, for me in my practice, the go-to surgical option for myopia, basically. So there has to be we can't do SmartSight for hyperopia. We can't do presbyopic laser vision correction for SmartSight. But if we're targeting, -1 as it was in your case, Ian, or as it normally is with younger patients, plano, then we will offer SmartSight. And then the main reason is that the dry eye recovery is so much quicker and so much more uneventful that it means people can get off their drops more quickly and they don't have to use them as often in the time after surgery.
There's a few changes in NHS cataract surgery that have happened certainly in my experience. There are a few private providers in our area kind of competing over all the cataracts in our area, which means there's no waiting list. So the changes I've seen for NHS patients for cataracts recently are: 1, there's no waiting list; 2, now one of the providers is offering extended depth of focus lenses; 3, I'm seeing a lot more PCO, and I'm also seeing a few patients have bilateral same-day cataract surgery. I've thrown 4 things at you there, but so if you wouldn't mind telling us some of the pros and cons and advantages and what your opinion is.
Whatever people's viewpoint is, the reality is in the UK, with respect to the provision of NHS cataract surgery, more NHS cataract patients are having surgery in the private sector than they are in actual NHS hospitals. So I can't tell you the exact statistics, but out of 400 to 500,000 NHS patients having cataract operations each year, over half are now happening in private sector, such as Spa Medica, CHEC and the like. And they've obviously come in with huge efficiencies. That's how the waiting list has come down. So the volume of work that they do has significantly reduced waiting times for patients, which means patients don't suffer as long with poor vision. I think it's important to recognise and acknowledge that. One of the main determinants of PCO is probably the kind of lenses that are used. So I don't know what lenses they're using there. And it may be that the lenses that they're using are a bit more prone to PCO than lenses that your local hospitals were using in the past. Surgically, you can do something called polishing the capsule, which might reduce the capsular opacification a little bit, but it's something that you probably wouldn't do if you were having to get through 20 or 30 in a day, because it takes a bit longer. So, you could say, look, maybe the way they're doing the surgery might increase the chance of PCO a little bit. I don't know. Could be that the patient expectation is higher. If they're using any kind of, extended range lens, then those lenses are often a bit more, patients are a bit more aware of PCO. So sometimes the PCO you see is because patients presented with PCO, not because they have PCO. Does that make sense? So it could be that the patients are more sensitive to it, but it's still the same amount of PCO. You'd have to look at the numbers to kind of be able to determine exactly what the difference is and what the cause is and what that might be. In terms of immediate bilateral same-day surgery, I think if you're operating with topical anesthesia on routine cases and you use a different batch of everything, which means that nothing that you're using in one eye comes from even the same batch as what you use in the other eye, and the surgeon unscrubs, puts new gloves on, i.e. you treat it as though it's 2 separate eyes of 2 separate patients, there's a lot of evidence to support that that's safe nowadays. And I think that when people look at how healthcare efficiencies can be delivered, that's something people will look back on. And whether that changes over the next 5 years or 10 years or 20 years, I do believe that it will become mainstream as it has done with refractive surgery. I think that, we don't know how many people are dying with one cataract and not able to navigate well, not having good stereoscopic vision, maybe falling over at home and breaking a hip because they didn't see the step or the rug that was lifted up that caused them to have a fall. But we do know that the quality of life and the impact on quality of life of having good vision and good eyesight in each individual eye is massive. So, if it was the case that we just had limitless capacity and we could just bring people in for one eye and then bring them in for the other and there was no waiting list, it might be a bit different. But I do in general support initiatives to make things more efficient in healthcare, because it's not, all of these things have got cost implications and it's not limitless the resource that is required to provide healthcare to an ever increasing elderly population where everyone is going to eventually develop cataracts. I mean, this is a problem that if you live long enough, you're getting cataracts. It's an inevitability. It's so unbelievably common.
Alan, so perhaps to wrap things up, this could be a very short answer to a question, but given that you're so busy with OCL, do you still have capacity for research, for dissemination at conferences and so on?
Yeah, I mean, I do believe in kind of paying things forward, which is that nothing that I've done personally in my career could have happened without inspiration, mentorship, teaching, guidance, and research that others have spent time doing. You know, I'm not here just to kind of practice medicine in the window of time that is my career and then wander off. I would love to feel that during that time I've contributed by teaching others things that they may not have known about before, or increasing their awareness of various technologies. And R&D comes into the same piece, if you like, which is that I personally, and also OCL Vision, we do have the opportunity to evaluate and integrate new and emerging technologies for the benefit of patients, which is really exciting. It's time consuming and difficult to do, but it's hugely rewarding. Like for SmartSight is a good example. We were the first in England and one of the first centres in the world to do it. And we now have 6 surgeons at OCL Vision all doing SmartSight. You know, it will become more commonplace. This is a technology now that's available to hundreds of our patients every year, and others will follow on. Same thing with new lenses. Many of the kind of lens innovations that come out worldwide, they are made available to us very early in the innovation cycle. And that allows our patients to have access to that kind of technology, but also for others to understand how the technology should be best utilised, because not everyone has the luxury of having, for example, optometric refractions on all their patients post-operatively. So we have that. We recognise it's a great luxury for us and our patients, but it also is a great source of information. If someone wants to know, you know, what kind of reading vision do you expect with this lens? We can answer all these questions. So we can use our clinical setup to inform on innovation and on best practice, not just within the private sector, because as you've already acknowledged, you know, some of these technologies are also available in the NHS. So to just try and raise the bar for healthcare, for eye care in the UK, that's a huge piece. And actually, R&D is one of my kind of roles in the business, if you like. That's one of the things that I spend time on and committed to doing. So yeah, so I still have time for it. I haven't replaced the NHS work that I was doing with additional private patients. I've used that time for these other things, these educational things, these R&D things, to kind of give back and contribute in other ways, basically.
And indeed, one of those education opportunities will be at 100% optical and also 100% ophthalmology in March of next year. So that's a mini tease there, maybe slightly earlier than I should be doing.
We're really excited, and I think it'll be fantastic. It gets better every year, and hopefully we'll try and make this year the best one yet.
Great. Allon, thank you very much for joining us today and for your time.
Thank you very much for having me. It's really nice speaking with both of you.
Thank you.